I'm really glad today to see that unicompartmental knee replacement in Pakistan is evolving. In the beginning, when I started my first uni knee here in 2018, obviously a lot of people were not quite receptive toward it, and the concept was that in Pakistani population, uni knee is not possible. That was the comments I used to receive. Now, 5 years down the line, it's really nice to see that a lot of colleagues are interested in doing partial knee. One thing we all need to know that it's not a replacement, actually it's a resurfacing procedure. If somebody comes to you with the varus, you do not overcorrect the mechanical access, you keep them in varus if you want to achieve good result. So, couple of terminologies which may be not new, but for youngsters who need to understand. So, when you do uni on the medial side, it's called MUCA, and when you do it on the lateral side, it's called LUCA. So, lateral unicompartmental knee arthroplasty makes it easier for us to understand. So, let's look at the introduction. We know that medial MUCA uni knee replacement is going on for many years. We have excellent result. We know the outcome. Now, this gentleman is almost 65. I've done bilateral side. He is doing yoga. So we know the fact that medial uni does work, and that's the reason the popularity and the numbers have gone up. In the last 10 years, I think 30 to 40% of patients are suitable for medial compartmental knee replacement. But 30%, like I said, are suitable for MUCA, and till date, only 1% of patients come up with isolated lateral compartment OA that can be suitable for LUCA. So many published data in the literature, like my colleague has just mentioned, are available to read about the outcomes of medial uni, but we don't have that much results or outcomes for the lateral side. But this is the topic of interest, and a lot of people are interested in looking at, can we do the same outcomes and results of patients who have lateral-sided isolated uni knee. We know from the fact that there are many advantages of uni. We have the result, but in early 1980s, when you look at the results, the medial side had very worse outcome. But when they looked at the literature on the lateral side, they found that during the same era, even though the lateral uni was done less, but the outcomes were better than the medial uni. So if you look at this paper by Insel and Scott, JBJS, published in 1980 and 1981, during that time, they not only did medial side, but also lateral side. Even though the numbers were small, in one study only 3, and in the second study only 12. A 7 years follow-up showed, and in 8-year follow-up, the better outcome in LUCA comparison to medial compartment, because obviously the design of medial side were primitive, the technique were not evolved, but for some reason, lateral side did better. We need to know the biomechanics of the knee to appreciate why lateral side is much more complex than the medial side. Lateral tibial plateau is more convex. C-shaped lateral meniscus is more mobile, more movement on the lateral compartment. And if you look at this, the biomechanical studies have shown that at 40 degree of flexion, femur displaces 4 to 5 millimeter in AP plane, moving the medial condyle anteriorly and moving the lateral condyle posteriorly, causing more forces on the posterior part of the lateral femoral condyle and tibia. So that's the reason when you cut the bone, which is a very small skim of bone, on the medial compartment doing uni, you will see anterior wear, central wear comparison to the lateral side, which shows more posterior wear. And that is visible when you are doing surgeries like that. Indication, like Mujahid Bhai already explained, we know the indication. Now the indication has expanded to a younger age population. We will debate about 3 factors today, which I think will cover not only lateral but also medial. So what should we do when the patient comes with isolated lateral compartment OA with overweight? Or what should we do when somebody comes with ACL that is not functional? So BMI clearly demonstrated that there is no major difference or influence outcome if you have a higher weight. So this lady, we did uni knee, 100 and almost, I would say 35 kg, 3 to 4 years follow-up. She's doing absolutely fine. If indication is right, unicompartmental knee replacement does not influence outcome in overweight patients. That has been proven now. ACL integrity, 2 things we need to know. Either it is traumatic injury, as somebody who is completely normal, 60 years of age, playing golf, suddenly twisted his knee, ruptured his ACL, and he's got instability. Should we do uni with unstable medial compartment OA secondary to traumatic ACL injury, or is it degenerative tear? So evidence have shown clearly, published in 13 and 14 by Murray and Gerard, that it does not cause any outcome difference if you have ACL tear or not, especially in the degenerative tear, because anyway, after 60, 55, the ACL becomes non-functional, and that's the reason you can still do fixed bearing. My preference is to do fixed bearing uni knee in patients who have got ACL tear, or even if they have ACL intact, especially in the elderly population. What is the Asian prediction? Because that is really important for us. Our patients here, they do squats, they have different expectation. Not a lot of paper been published, but recently, 2016, Journal of Osteoplasty, big number of cases were done in Asian population. 724 unis, 2 years follow-up, 92.2% satisfaction and improved range of movement. So what's the approach we should use to do lateral uni? Lateral is not easy to do. Even medial uni are not easy to do. It's a big learning curve. You need to understand that you hardly release the MCL, you hardly do anything. So it's a very small compartment to implant. It's a difficult job. But the lateral approach, evidence have shown that both approaches are fine. You can do medial approach, you can do lateral approach, but lateral approach has shown to be much more easier. I did my lateral unis with the lateral approach. I feel it's much more easier. You can go through the center of the patella if you're doing the tibia cut. You can go slightly from the more out of the patella tendon. But ideally, if you want to do lateral uni, you can go through the center of the patella by making a nice incision and cut the tibia. Also, always open up the knee joint, examine the patella. Like in this case, it's not a lateral, it's a medial uni. Just for demonstration, I open everything up. If I have any doubt, and I will convert that into a total knee replacement straight away. Like in this case, the patient had arthritic changes, ulcers on the other side, and I prefer doing total knee. So always keep backup of total knee implant when you're doing partial knee replacement. And survivalship, evidence have shown through the lateral approach is 100%, 10 years in the study which I've just written here. So what are the survivalship of lateral uni? Not a lot of literature available. So very few papers been published on the lateral uni, and they have compared overall all type of unis, all poly, mobile bearing, metal back. But I think the most strong evidence coming up toward the lateral uni is metal back. Lateral uni do better. And overall survivalship of LUCA has improved since it was attempted, and the literature has shown survivalship of 5 to 10 years time excellent. So robots, we have now new paper coming up. It doesn't make any difference, but in some studies they do show that robotic surgery actually gives you better outcome in early stages rather than long term. But it's still debatable. Some of the strong papers are coming up showing that there is no long-term outcome difference between robots and non-robots. We will open this debate soon. So MOCA experience in Pakistan, like I said, started in 2018. I've done over 100 now, 1 revision required. And this is the gentleman who came from Quetta. He is quite big and tall, you can see. I think it's coming up to almost now 4.5, 5 years down the line. And they do very well. They can even do praying position. The lateral compartment is well preserved. And let me show you my experience from UK. We've done, I think, 15 lateral uni. This lady coming up to, this was not long term, but this guy I want to show you. So this is 5 years down the line, lateral uni. He is 71. We did him, I think, when he was 65 or 66. Full range of movement. X-ray does not show very amazing picture comparison if you look here, comparison to medial uni, but they do well if the selection criteria, so this was all poly we did by Corin, the Corin implant in Circle Bath Hospital. So, in conclusion, LUCA is not very much utilized. In last 10 years, more interest has developed toward utilizing lateral unicompartmental knee arthroplasty. Right patient selection is very key, and recent evidence showing excellent result. We need more research to justify that it is as good as medial uni. Thank you very much. So I would like to welcome you all to come and visit our beautiful Pakistan, all our international guests. This is Skardu, and I think we have a very beautiful places where you guys can go and enjoy and see the beautiful mountains of Pakistan. Thank you.